Hi, I'm Ashley, and in 2009, at 38 years old, I was diagnosed with a pancreatic neuroendocrine tumor. This is the same kind of cancer that killed Steve Jobs. Although his tumor was a glucogonoma, mine was non-functioning, which means it didn't secrete any hormones, and it didn't carry any type of syndrome with it, so I didn't have a heads up, and the tumor was found incidentally. After I made a joke to a friend of mine who happens to be a physician, I made a joke about lip hair, and instead of laughing, he sent me for labs because he suspected an adrenal tumor or some type of problem with the adrenals. I went and had the labs, and there was an elevation of a certain testosterone hormone, but it was independent of any other hormonal fluctuations. And so that was atypical in a diagnosis of an adrenal tumor, and he sent me to get a CT just to be sure. And the adrenals were all clear, but the pancreas held a little surprise in it, and that's how we were alerted to the fact that there was a problem. So I went for a biopsy, which I wouldn't recommend in hindsight, because if you have a pancreatic tumor that needs to come out anyway, don't go poking around in there. And there are other risks that it's kind of controversial, but there's something called seeding, and it has been indicated or mentioned in medical literature. And what that is in order to get a sample of the cells in a tumor in the pancreas, they have to go through the stomach, because the pancreas is behind the stomach. It's very deep in the body. So they sedated me and put a scope down my throat, and had a little camera on it and a needle, and they were going to poke the needle through the stomach wall and into the tumor in the pancreas, and try to aspirate some of the cells from the tumor, bring them back out. But in order to do that, they have to pull it out through the stomach. So when the needle drags through the stomach, the theory is that some of the cancerous cells can sort of implant, start to grow in the stomach, and then voila, you have spread your cancer. Some doctors will laugh at that, but you're the one who makes decisions for yourself. So in hindsight, I wouldn't ever do that again if it has to come out anyway. So we received a certified letter from the lab, and the letter said that that I had been affected negatively by a faulty assay that they had for a 2-week period of time, and they were sorry for any inconvenience, but my blood tests were 100% normal. So that was the weird testosterone elevation. There wasn't one. It was a fluke, and I'm so thankful for the mistake, because that's how we found out about the cancer. And although I had some enlarged parapancreatic lymph nodes, they came back negative after surgery. So that's better than being told they came back positive, and it has not shown up in the liver yet. I had surgery. I had a distal pancreatectomy splenectomy, which means they took the pancreas and cut a small portion of the body and the tail off, because that's where my tumor was. Many tumors are in the head, but mine was not. And they found a couple of other little tumors that were too small to be visualized on CT scans and MRIs and all that on the pathologist table. But it turned out to be the neuroendocrine tumor. The spleen had to go because it shares close blood supply with the pancreas, and sometimes they can preserve it, I'm told, and sometimes they can't. And when it looks like, when it's iffy, they go ahead and take it out, because they don't want to run the risk of your spleen not getting enough of the blood supply after the surgery, and then having your spleen, atrophy and die, and then you become septic and then you die. So in order to avoid all that, they just take the spleen out. And there's some differences of opinion on how you live after you have your spleen removed, because you should have. They say you should have flu shots, and antibiotics become a part of your life, because when you get sick, you can have a crisis. You can die from the flu, or something bacterial in nature can overtake your system, because your spleen is a big part of your immune system. Many people just live like they always lived afterwards, and they don't do all that stuff. I don't take antibiotics every time I have a high fever or anything like that. I just push through it, and I've been fine so far. But there is a risk. So I guess it makes you immunocompromised, if you want to look at it that way. I didn't need any chemotherapy because it hadn't spread, and I've been 3 years in ED now, and the way NED means no evidence of disease, and the way they maintain my situation is they scan me twice a year. I get MRIs now because I don't like the amount of radiation in the CTs. It was personal choice, and they let me do it. I had an octrio scan once, but it was post-surgery. I would recommend if you've just been diagnosed with this and have a tumor, try to get an octrio scan before they remove the tumor, because it will do a couple things. It's good imaging to see if you have any metastases, and it also they inject, I think it's somatostatin, into you as part of the visualization process. And if your tumor has somatostatin receptors, and all of them don't, but some of them do, from what I understand, I'm not an expert. If it has those receptors, that lights up and shows on the scan, and then what that tells them is that later on, or even right now, your cancer might respond well to certain chemotherapy that has somatostatins in it. So those are the benefits of an octrio scan, if you can get it. I didn't, but water under the bridge now. So they scan me now twice a year, like I said, and they do blood tests. They look for serotonin, and they look for chromogranin A, which is a tumor marker for neuroendocrine tumors. And chromogranin A is elevated in a fair majority. Oh well, I think it's like 60%. I shouldn't use numbers. In a fair number of cases, let's say that chromogranin A is elevated. So that may be a good way to give us the heads up that even though we maybe are not seeing something on the scan, something may be going on a microscopic level. So doctors can make treatment decisions based on that, or they make the recommendations. We make the decisions. Okay. That's basically it. I'm a mom. I have a child with special needs. I have a younger child, and don't want to be going anywhere anytime soon. And it's scary a little bit. My tumor pathology came back, and my Chi staining was less than 1%, and my mitotic rate was 1 in 10. And basically what these things mean is that my tumor in particular was very indolent. It's still cancer, so that's why I still have to get checked out. And I know people who have had this type of cancer for 30 years. I know of them. And basically what seems to happen is they have a recurrence after a period of time. They have medical intervention. They get it cut out. They get it, nuked with chemo or whatever, and they deal with it. And it's like a chronic disease. And then it looks like there comes a point in the journey where, they can't cut it out anymore. They can't have a surgical intervention, and then you go through the process. From what I've read in medical literature, when it metastasizes to the liver, that's generally the modus of exit. I have tried to get my doctors to confirm this, and they won't. They stay very positive and very upbeat. They don't want to talk like that, and they don't want to talk with you like that. So you read the literature, and which can be good and which can be bad in some cases. Sometimes knowing too much is not helpful. But I'm in a really good position because it was found earlier, and because of the incidental finding, and I feel pretty good about that. I'm grateful for that. I'm grateful for each day. I've had phone calls in the past where my chromogranin A levels would fluctuate a little bit, and that would, it would freak me out. It's easy to be calm when nothing is going on, and it's a little more difficult when you get news you don't want to hear. But anything gets old, even worrying about your own life and death. So you cope and I enjoy my life, and I'm a very happy person and a very grateful person. And I would say to anybody out there who has this, um, it's the, this kind of seems lame, but it's true. This kind of cancer is the best, worst news you can get because the tumor could have been adenocarcinoma, and that is a very aggressive cancer. I'm not saying that some neuroendocrine tumors aren't aggressive, obviously. Um, when you look at people like Steve Jobs, you know that there's a reality there that can be unpleasant, obviously. But people like Michael Landon and Patrick Swayze, Fred Gwynn, Henry Mancini, Sally Ride. These people were people who got the other kind of tumor, the adenocarcinoma, and it's very aggressive, and not very few people survive it. So with this cancer, this best worst news you could ever get, it's right now it can be kind of be looked at as a chronic disease in many cases, and I guess we get what we get, and we don't pitch fit, and there's so much life to live and so much to be grateful for. I don't sit around spending whatever time I do have completely freaking out about it and being sad and bitter. I don't want to do that. Life is great, and God is good. And if you want to contact me, if you've just been diagnosed and you're freaking out, and you just want to talk about that, please feel free to send me a message. Thanks for watching.